Welcome. Welcome to the session of absorption and bioavailability. I'm Dr. Jayababu, Assistant Professor, Department of Pharmacology, Kakatiya Medical College, Warangal. We have certain objectives. By end of this session, the MBBS Phase 2 student should be able to explain the term pharmacokinetics, explain 4 phases of pharmacokinetics, explain why the understanding of pharmacokinetics is relevant to prescribers. Should be able to describe the biological membrane and transportation of drugs across biological membrane, define absorption of drugs, explain various factors affecting absorption of drugs. The MBBS Phase 2 student should explain the concept of bioavailability and describe the factors affecting bioavailability, and also they describe the importance of bioequivalence. These are the objectives the MBBS Phase 2 students should know about in the session absorption and bioavailability. From these objectives, you will get questions in the exam or may be asked in the Viva. Pharmacokinetics. The study deals with the drug movement in the body, through the body, and out of the body. It shows how the human body act on the drugs. So pharmacokinetics is a quantitative study of drug movement in the body, through the body, and out of the body. The intensity of effect is related to concentration of the drug at the site of action, which again depends on its pharmacokinetic properties. The word pharmacokinetics has two words: pharmakon, meaning drug, kinesis, meaning movement. In short, it is what the body does to the drug. And pharmacokinetics includes absorption, distribution, metabolism, and excretion. Pharmacokinetics includes absorption, distribution, metabolism, and excretion. The aim of drug therapy is to supply the drug in adequate concentration at the targeted sites. To achieve this, the drug should get absorbed adequately, distributed, and should reach the target site in shortest interval. Later, the drug should be metabolized to make it inactive and water soluble, and to be eliminated through different routes. the entire process of absorption, distribution, metabolism, and elimination is termed as pharmacokinetics. The pharmacokinetic properties of a drug determine route of administration, dose of the drug, latency of onset, time of peak action, duration of action, and frequency of drug administration. So pharmacokinetics involves absorption, distribution, metabolism, also called biotransformation, and excretion. The drug administration, after the drug administration, there is a direct absorption of the drug, and also there may be intrahepatic passage and absorption, and the drug entry of the drug into systemic circulation after attaining the blood levels. Drug is it may be in the form of bound form or in the free form. The free form of the drug gets into systemic circulation, and some of the drug may be stored. The distribution, after distribution, there is metabolism. And after the metabolism, there is elimination or excretion of the drug, mainly to the kidney. Drug excretion occurs through urine, bile, feces, sweat, and saliva. So the processes involved in the pharmacokinetics are absorption, distribution, metabolism, and excretion. After the dosing regimen, the pharmacokinetics is involved, that is absorption, distribution, metabolism, and elimination. Then there is a concentration in plasma. Later, there is a concentration at the site of action. Then, after the action of the drug, effects are observed. So coming to the importance of pharmacokinetics, there is optimal dosing regimen and frequency is chosen. It explains individual variation in response to drug therapy. Fate of the drug in normal individuals and different pathophysiological conditions. The effect of drug can be known. Distribution, penetration, location, concentration, response, clearance, and bioavailability of drugs can be determined. Pharmacokinetics compares dosage forms and different drug brands, evaluates quantitatively the magnitude of drug interactions, and pharmacokinetics also provides the basics to make clinical predictions. Cell membrane. also called as plasma membrane, plasma lemma, or phospholipid bilayer. As you are fresh from the physiology, now you have passed out recently, you should be thoroughly knowing the cell membrane physiology. Cell membrane mainly consists of lipid bilayer, that we have phospholipid, cholesterol, and glycolipids, proteins, integral membrane proteins, lipid anchored proteins, peripheral proteins. The biological membrane, it is a bilayer made up of phospholipids, cholesterol, polar groups are oriented at the two surfaces, and the non-polar hydrocarbon chains are embedded in the matrix to form a continuous sheet. So, biological membrane is a bilayer made up of phospholipids and cholesterol. The polar groups are oriented at the two surfaces, and the non-polar hydrocarbon chains are embedded in the matrix to form a continuous sheet. Extrinsic and intrinsic protein molecules are absorbed on the lipid bilayer. Glycoproteins or glycolipids are formed on the surface by attachment of polymeric sugars, amino sugars. The specific lipid and protein composition of different membranes differs according to the cell or the organelle type. The proteins are able to freely float through the membrane, associate and organize. Some of the intrinsic ones, which extend through the full thickness of membrane, surround fine aqueous pores. Paracellular spaces or channels also exist between certain epithelial or endothelial cells. Other adsorbed proteins have enzymatic carrier, receptor, or signal transduction properties. Lipid molecules are also capable of lateral movement. Thus, biological membranes are highly dynamic structures. So, the process of absorption primarily across the cell membranes. The process occurs primarily across the cell membranes and later in the gastrointestinal tract. Movement of the substances across the cell membranes, gases, hydrophobic molecules, small polar molecules move through it easily. Large polar molecules, charged molecules are unable to move across the biological membrane. The cell membrane is a mosaic structure composed of an interrupted by a bimolecular lipid layer with fluid-like properties. It also consists of a smaller component of glycoproteins or lipoproteins that are embedded in the lipid matrix, and ionic and polar groups protruding from one or both sides of the membrane. The interrupted lipid layer consists of pores or channels through which drug molecules enter the cell. The intercellular gaps in the vascular endothelium are very tight and are packed with loose matrix of proteins which act as filters, allowing the passage of small molecules only, leaving behind the bigger ones. So absorption, definition of the absorption, it is the passage of drug from the site of administration into the circulation. Absorption is the passage of drug from the site of administration into circulation. All the pharmacokinetic processes involve transport of the drug across biological lipid membrane. So all the biological membranes are made up of lipid bilayer. Drugs cross various biological membranes by the following mechanisms. Those are passive diffusion, filtration, that is specialized transport, carrier transport, that is active transport, and facilitated diffusion. Coming to the types of transport, we have passive transport. In that we have passive diffusion, filtration. Specialized transport, it includes carrier transport. In that we have active transport and facilitated diffusion. Passive diffusion, it is a bidirectional process. The drug molecule moves from a region of higher concentration to lower concentration until equilibrium is attained. The rate of diffusion is directly proportional to the concentration gradient across the membrane. Lipid-soluble drugs are transported across the membrane by passive diffusion. It does not require energy. So passive diffusion, the lipid-soluble unionized drug diffuse across the lipid biomembrane in the direction of the concentration gradient. It does not require energy. Filtration. Filtration depends upon the molecular size and weight of the drug. If the drug molecules are smaller than the pores, they are filtered easily through the membrane. So filtration is the passage of drug through aqueous pores in the membrane through paracellular spaces. The moving force is hydrostatic or osmotic pressure. Lipid insoluble drugs cross biomembrane by filtration. Carrier transport, the carrier molecule which acts as a ferry boat across the lipid region of the membrane. Carrier transport is saturable and competitively inhibited by analogs which utilize the same carrier. The specialized transport includes active transport. The drug molecules move from region of lower concentration to higher concentration against the concentration gradient. It requires energy. For example, transport of sympathomimetic amines into neural tissue, transport of choline into cholinergic neurons, absorption of levodopa from the intestine. So active transport is a movement against the concentration gradient. It needs energy. It is inhibited by metabolic poisons, Levodopa and methyl-dopa are actively absorbed from the gut by aromatic amino acid transport. Facilitated diffusion. This is the type of carrier-mediated transport and does not require energy. The drug attaches to a carrier in the membrane, which facilitates its diffusion across the membrane. The transport of molecules is from the region of higher to lower concentration. For example, transport of glucose across muscle cell membrane by a transporter GLUT4. So the facilitated diffusion, this process more rapidly than passive diffusion and translocates even non-diffusible substrates. It along their concentration gradient. For example, facilitated transport of glucose. Pinocytosis, it involves the invagination of the part of the cell membrane and trapping within the cell of small vesicle containing extracellular constituents. Example, insulin through blood-brain barrier. So drug absorption is important to determine the frequency of drug administration, to ascertain the duration of effective action, and to predict the onset of desired or undesired effects of the drug. Drug absorption determines the frequency of drug administration, to ascertain the duration of effective action, and to predict the onset of desired or undesired effects of the drug. Coming to the bioavailability. Bioavailability is defined as the amount of drug that is absorbed from a given dose form and reaches the systemic circulation following the non-vascular administration. So bioavailability is defined as the amount of drug that is absorbed from a given dosage form and reaches the systemic circulation following the non-vascular administration. Bioavailability is the availability of the biologically active drug. It refers bioavailability refers to the rate and extent of absorption of the drug from dosage form. It refers to the rate and extent of absorption of the drug from dosage form as determined by its concentration time curve in blood or by its excretion in the urine. It refers to the rate. Rate is at the time bound, time taken by the drug or absorption. Extent is amount of the drug absorbed. Dosage may be a gaseous form or liquid form or solid form. So it is bioavailability is denoted by the fraction F, the symbol F. It is a measure of the fraction of the administered dose of the drug that reaches the systemic circulation in the unchanged form. So bioavailability is a fraction of the administered dose of the drug that reaches the systemic circulation in the unchanged form. Bioavailability of the drug injected IV is 100%, but it is frequently lower after oral ingestion. Bioavailability is lower after oral ingestion because the drug may be incompletely absorbed. The absorbed drug may undergo first pass metabolism in the intestinal wall or liver or excreted in the bile. The drug may be incompletely absorbed or it may undergo first pass metabolism. So after oral ingestion, the bioavailability is low. The bioavailability of drug injected intravenously is 100%. So bioavailability, the single dose bioavailability test involves an analysis of plasma or serum concentration of the drug at various time intervals after its oral administration and plotting a serum concentration time curve. It provides information about the following. By plotting a plasma concentration y-axis and time at x-axis, it provides information regarding the maximum concentration achieved after absorption, that is Cmax, maximum concentration achieved after absorption is Cmax. The time taken to achieve the Cmax is Tmax. The area under the curve, which gives idea about the extent of absorption. The shape of the area under the curve, which gives idea about the rate of absorption. So by plotting the plasma concentration time curve, we're able to know the maximum concentration achieved after absorption, that's Cmax. Time taken to achieve the Cmax is Tmax. Area under the curve, which gives idea about the extent of absorption. The shape of the area under the curve, which gives idea about the rate of absorption. So bioavailability, it is area under the curve oral by area under the curve IV into 100. These are the measurement of the bioavailability can be done by area under the curve after oral dose divided by area under the curve after IV dose into 100. So the plasma drug concentration and time at the x-axis and y at the plasma of drug concentration at the y-axis. We can know the concentration achieved, time taken to achieve the concentration, extent of absorption, and the rate of absorption. So the starting point of the curve shows the absorption, and the ending point of the curve shows the elimination. We have minimum effective concentration and maximum safe concentration. The concentration between minimum effective concentration and maximum safe concentration, that is the therapeutic index. So the drug which lies within the therapeutic index is a drug considered as a good therapeutic index drug. The drugs which fall below the minimum effective concentration, or the drug which crosses the maximum safety concentration, are not therapeutically useful drugs and may have side effects. Here, the graph shows therapeutic success of a rapidly and completely absorbed drug, therapeutic failure of the slowly absorbed drug, the magnitude of the drug that comes into systemic circulation, but also the rate at which it is absorbed is also important. The plasma drug level curves following oral administration of 3 formulation of the same basic drug. We have minimum toxic concentration, or maximum safe concentration, and minimum effective concentration. The area between the minimum effective concentration and maximum therapeutic concentration, or maximum safe concentration, is therapeutic range. For the formulations A and B, the areas under the curves are identical. The formulation A would produce quick onset and short duration of action compared to formulation B, whose effect would last much longer. The formulation A would produce quick onset and short duration of action. Formulation B will show the action which would be longer in action. Formulation C gives inadequate plasma levels and therefore likely to be therapeutically ineffective. So the drug which lies in the area between the therapeutic range are considered the therapeutically useful drugs. We should consider the drugs which are falling between the minimum effective concentration and maximum safe concentration. That is in the therapeutic concentration. Those for drugs which are falling in this concentration or range, therapeutic range, are considered to be safe and good drugs. Those drugs which follow below the minimum effective concentration or which may go above the maximum safe concentration are considered to be drugs with side effects and or adverse effects. Bioequivalence. Drug formulations are considered to be pharmaceutically equivalent if they contain the same active ingredients and are identical in strength, concentration, and dosage forms. Drug formulations are considered to be pharmaceutically equivalent if they contain the same active ingredients and are identical in strength, concentration, and dosage forms. The pharmaceutically equivalent drug formulations are considered to be bioequivalent. The pharmaceutically equivalent drug formulations are considered to be bioequivalent when the rates and extent of bioavailability of the active ingredients, when the rates and extent of bioavailability of the active ingredients in the two formulations do not differ significantly. In the two formulations do not differ significantly when tested by standard procedures. When tested by standard procedures, such substances are likely to be therapeutically equivalent. Such substances are likely to be therapeutically equivalent. So, if two formulations of the same drug produce equal bioavailability, they are said to be bioequivalent. If the formulations differ in their bioavailability, they are said to be bioinequivalent. So the factors affecting the drug absorption and its bioavailability, they are the same factors which observe drug absorption and also its bioavailability. Drug related, we have physical properties of the drug, nature of the dosage form. Patient related, physiological factors, pharmacogenetic factors, disease states. Drug related, we have physical properties, physical states. Liquids are absorbed better than solids, and crystallites are absorbed better than colloids. Physical state, liquid form of the drug is better absorbed than solid formulations. Lipid or water solubility, drug in aqueous solution mix more readily than those in oily solution, with the aqueous phase at the absorption site and hence are absorbed fast. At the cell surface, the lipid-soluble drugs penetrate into cell more rapidly than the water-soluble drugs. At the cell surface, the lipid-soluble drugs penetrate into cell more rapidly than water-soluble drugs. Bile salts assist the absorption of fat-soluble vitamins A and D in the small intestine. So, lipid-soluble and unionized form of the drug is better absorbed than the water-soluble and ionized form. Lipid-soluble and unionized form of the drug is better absorbed than the water-soluble and ionized form. Dosage form, particle size. The particle size of sparingly soluble drugs can affect their absorption. Small particle size is important for absorption. Drugs with smaller particle size are absorbed better than the larger ones. For example, microfine aspiration, digoxin, and cryptophyllin are well absorbed from the gut and produce better effects. Some of the anti-elementics have larger particle size. They are poorly absorbed through the gastrointestinal tract. Disintegration time and dissolution time. The disintegration time, which measures the rate of breakup of the tablet or the capsule into the drug granules. The disintegration time, which measures the rate of breakup of the tablet or the capsule into the drug granules. And the dissolution rate, which is the rate at which the drug goes into solution. The dissolution rate, which is the rate at which the drug goes into solution. The disintegration time of a tablet is a poor measure of bioavailability of the contained drug. The dissolution rate is perhaps a better parameter. So disintegration time, it's a time taken for the formulation tablet or a capsule to break up into small particles, and its variation may affect bioavailability and absorption. Dissolution time, it is the time taken for the particles to go into solution. Shorter is the dissolution time, better is the absorption. Physiological factors. Ionization. The mucosal lining of the GIT gastrointestinal tract is impermeable to the ionized form of weak organic acids and weak organic bases. The body pH, most of the drugs exist in two forms. An unionized component, predominantly lipid soluble, and an ionized water soluble component. The unionized fraction can cross the cell membrane rapidly. So weakly acidic drugs, for example, barbiturates in unionized form in the acidic pH in the stomach are better absorbed from the stomach. Weakly basic drugs, for example, morphine, amphetamine, in unionized form at alkaline pH are better absorbed from the intestine. So the pH of the gastrointestinal fluid and the blood, the weakly acidic drugs are rapidly absorbed from the stomach. They act rapidly on oral administration, salicylates and barbiturates. Weakly basic drugs are not absorbed until they reach the alkaline environment of the small intestine. Strongly acidic and basic drugs are highly ionized and hence they are poorly absorbed. Gastrointestinal transit time, the presence of food and the volume, viscosity and tonicity of the gastric contents can influence the drug absorption by altering the gastric emptying time. Rapid absorption occurs if the drug is given on empty stomach. So the presence of food, absorption of most of the drugs from the gastrointestinal tract is reduced by the presence of food in the gut, and also food aids in the absorption of the certain drugs. The food also hinders the or reduces the absorption of certain drugs. The food which is increasing the absorption of drugs like chloroquine, carbamazepine, cryptophyllene, lithium carbonate, nitrofurantoin, riboflavin, spironolactone. Food hinders the absorption, decreases the absorption of ampicillin, aspirin, captopril, digoxin, isoniazid, levodopa, penicillin G, rifampicin, tetracycline. Increased peristaltic activity, as seen in diarrhea, reduces the drug absorption. So in diarrhea, there is increased peristaltic activity leading to reduction of drug absorption. Anticholinergic drug, which prolongs the gastric emptying time, also impairs the absorption of certain drugs. Enterohepatic circulation or cycling. A number of drugs form conjugates with glucuronic acid in the liver and are excreted in the bile. A number of drugs form conjugates with glucuronic acid in the liver and are excreted in the bile. These glucuronide conjugates are highly ionized and hence they are not reabsorbed and remain in the gut. Then they are hydrolyzed by gut enzymes and bacteria, releasing the parent drug, which is then reabsorbed. The reabsorbed drug undergoes stress conjugation reactions. The process is repeated many times. This helps to sustain the plasma concentrations for longer periods, and the drugs affected are cefurazone, sulindac, and ethinyl estradiol, which is present in many oral contraceptives. Intrahepatic cycling increases the bioavailability of the drug. The area of absorbing surface and local circulation. Drugs are absorbed better from the small intestine than from the stomach because of the larger surface area of the small intestine. First pass metabolism. The liver is the principal site of metabolism for majority of the drugs. But the certain drugs may be inactivated in the gastrointestinal tract before they are absorbed. This pre-systemic or first pass metabolism is mediated by cytochrome P450 present in the enterocytes lining in the small intestine and may account for nearly 50% of the entire cytochrome P450 mediated metabolism. So that when the drugs are administered orally, they have to pass through gut wall, portal vein, liver, and systemic circulation. During this passage, certain drugs get metabolized and are removed or inactivated before they reach the systemic circulation. This process is known as first pass metabolism. The net result is decreased bioavailability of the drug and diminished therapeutic response. Drugs, for example, lignocaine in the liver and isoprenaline in the gut wall. So first pass metabolism refers to the metabolism of a drug during its first passage from the site of absorption into the systemic circulation. Bioavailability of certain drugs is reduced by rapid metabolic degradation during its first passage. The consequences of first pass metabolism. Drugs which undergo extensive first pass metabolism are administered parenterally. For example, lignocaine is administered intravenously in ventricular arrhythmias. The dose of the drug required for oral administration is more than that given by other systemic routes. For example, nitroglycerin. Presence of other agents. So vitamin C enhances the absorption of oral iron, while the phytates reduce it. The absorption of fat-soluble vitamins is reduced in the presence of liquid paraffin, whereas cholesterol absorption is reduced by cystosterol. So the presence of food in the stomach can affect the absorption of some of the drugs. Food decreases the absorption of rifampicin, levodopa. Hence, they should be taken on empty stomach for better effect. Milk and milk products decrease the absorption of tetracyclines. Fatty meal increases the absorption of griseofulvin. Like the presence of other agents. Ascorbic acid increases the absorption of oral iron. Antacids reduce the absorption of tetracyclines. Pharmacogenetic factors. The genetic factors may influence the drug absorption. In pernicious anemia, vitamin B12 is not absorbed from the gut due to lack of intrinsic factor. Likewise, there may be examples like G6PD deficiency, slow or fast facilitators. Some of the patients with pseudocholinesterase or inactive cholinesterase. The disease states absorption in the first pass metabolism may affect in conditions like malabsorption, thyrotoxicosis, echlorhydria, cirrhosis of liver, and biliary obstruction. So the valid tests of bioavailability of drug preparations, the levels of drug in biological fluids such as plasma, urine, and saliva, and an objectively measurable parameter of its therapeutic efficacy, heart rate, and blood pressure. Therapeutically, bioavailability is more important in the case of drugs with a narrow therapeutic index, for example, digoxin and aminophylline. So these are the factors which are affecting the drug absorption and bioavailability. By end of the session, the MBBS phase 2, students should know all these objectives covered under pharmacokinetics, that is absorption and bioavailability in this session. By the end of this session, you should be able to explain the term pharmacokinetics, the 4 phases of pharmacokinetics. Why is the understanding of pharmacokinetics is relevant to the prescribers? You should be able to define absorption, describe biological membrane and transportation of drugs across the biological membrane, explain the principles involved in the drug absorption, various factors affecting the absorption of the drugs and bioavailability, explain the concept of bioavailability, and give the importance of bioequivalence. Thank you.